Dr. Parmer Schwartz on vacation, so I'm going to go ahead and introduce this morning's Grand Rounds presenter. We have Dr. Jonathan Freezer, who is a pediatric hospitalist here at Carilion. He was in the charter graduating class from Virginia Tech, and he completed his residency in pediatrics with Geisinger and went on to work in the field of pediatric hospital medicine for the last 9 years. During his career, he has utilized his interests in medical history and healthcare communication to not only improve his delivery of effective healthcare in a population with a less than 65% immunization rate, but as chief of staff, he has further used his skills in population health and communication to help navigate a hospital through institutional crisis. He and his wife moved back to Roanoke in October of 2025, bringing along 2 cats and 2 dogs, and a love for local cuisine, music, and the arts. They are proud members of the VTC Pediatric Residency Fan Club, and he's very excited to start teaching this fall for the same medical school that raised him. Good morning, Dr. Freezer.
Good morning, everyone. So, mistrust is definitely a topic near and dear to my heart. General anxiety is a tradition in my family, and I feel like, talking about institutional crisis, I've been in multiple situations where I felt like there were multiple situations where trust in the institution I was a part of has been shaken up. And I think one of the first experiences that I was involved with is, I'm a Penn State alumni. And so when the whole Sandusky scandal went down, that was hard on all of us. It's the first time you see the fallibility in your leaders, for a lot of us, and that was very difficult emotions. And I happened to be really good friends with a lot of the people that were working with Penn State through that crisis, and seeing it from that perspective. And a lot of those skills then just developed over time. And so by the time I was a chief of staff at Washington State, we were experiencing multiple scandals. We had a scandal that pretty much required us to shut down our emergency department and rebuild. We had a financial crisis, and then on top of that, the population that we were serving had a less than 65% immunization rate, so there was already quite a mistrust in the healthcare system. And so navigating through those waters, it is a very interesting topic. But I also want to point out that, before I even get into that, I'll have a little slide that we'll talk about. For this topic, the 2 things I want you to keep in mind. One is, it's very hard to talk about a topic like this and not spark some feelings in people of, oh, Dr. Freezer's being political. I'm not trying to be political. I personally, I've just unplugged from politics. I can't handle it. So if you are, getting a little agitated by something that I may say off the cuff, really, please know that I'm not trying to attack one political party or the other. The other thing is that in our careers, we change who we are as physicians. We're constantly changing. And I think at the time where we've gotten our career completely figured out, that's when we're at our retirement party, right? And so, a lot of us may, at some point in our career, may have this strategy where our job is just to present the facts, and whatever the patients do with it, that's on them, right? Other of us might be in a spot where we might be trying to negotiate appropriate health care with our families, and saying, hey, I understand you might not like these options that are recommended, but can I swing you towards these options? And so if you're in that former category where you're just like, here are the recommendations, do what you want, some of this presentation might not completely align with your practice. But I do hope that there are some things that you're able to get out of it. So going on. So we're going to start with a story. And this probably sounds really familiar, right? So feel free to nod your heads if this is in your sphere. So the globe a global pandemic hits. During this global pandemic, there's a lot of panic. But then soon after the panic, you start seeing a lot of angry voices about masking. People start saying that masking is an offense to civil liberties, and that masking is ineffective, and on and on and on. And then we get an immunization that's developed, and we're really excited about that. But then all of a sudden, you're hearing these really loud voices talking about this immunization is probably causing more harm than good. And well, gosh, moving on, then a couple of years later, we see a really, really strong anti-immigration movement that develops within the country, and you start seeing governmental policies that really focus on immigration. And and then you start seeing this really loud proponent of voices within the community that are starting to talk about these single source cure-alls, where this treatment that can be administered for things like cancer now and infectious disease, and it can be used to treat everything. And well, gosh, we need to get away from medications altogether and really just focus on health and diet. This all sounds familiar, right? Right? Because obviously I'm talking about the Spanish flu of 1918. And that's what I am talking about. This all happened with the Spanish flu. Spanish flu, we saw the exact same things happen. When we started masking, there was a large voice, the Anti-Masking League out of San Francisco, started making appeals to government that this was against our civil liberties. We started producing inoculations, not for influenza during the Spanish flu, because we didn't isolate Spanish flu until the 30s. But what we were doing is that we were using killed strains of streptococcal, staphylococcal, and also Haemophilus influenzae bacterium. And what we were able to do with those killed strain inoculations is that we were actually able to reduce the rates of mortality due to secondary pneumonia from the Spanish flu. But a lot of people got up in arms about those immunizations as well. During the 20s, the early 20s, following the Spanish flu pandemic, which finished up around 1920, we had probably one of the largest anti-immigration movements become incredibly vocal, really towards anti-communist sentiment at the time. And there was also a lot of anti-German sentiment too. There was a lot of conspiracy theories that inoculation that I talked about was being poisoned by German agents, and a lot of kind of radical beliefs out there. The 1920s is where we see the rise of radiation as a cure-all, where people are using radiation for everything, for arthritis, for seasonal allergies. It was being touted as this miracle cure-all. And then a real focus on nutrition and some really kind of really interesting ideas regarding nutrition that all sort of fell through. But what I want you to take away from this is that we see a reproducibility in history to mistrust, right? We had a big outbreak in Spanish flu, we had a big outbreak with COVID, and a lot of the responses are predictable, right? And if it's predictable, then what I'm arguing is that mistrust isn't some elusive behavior that we're trying our best to cope with. No, it's something that we can prepare for. It's something that we can alleviate. And there's real world strategies that we can employ to help reduce mistrust. This is a very organic phenomenon. Okay. One thing I want to make sure that we're all clear on, because I get frustrated with this too. This was just from JAMA this month, right? And every time you read an article about patient mistrust in healthcare, you see sentences like this. It is the responsibility of clinicians to engage patients and parents with empathy, address misinformation directly, and advocate for accessibility and culturally sensitive immunization efforts. Right? This is an article about the resurgence of tetanus, right? And that's this month. Does this frustrate you as much as me? All you gotta do is present the facts, man. And then all that mistrust is just gonna go away, right? How many people in this room can honestly say that the facts are doing anything? Facts are just, they're stagnant, they're not helping, right? And so this is not a presentation that's just gonna tell you, oh yeah, you just gotta present the facts. No, I'm gonna try to give you real world strategies that can be effective. And I'm also gonna say too, you are gonna have patient families, and you already know this, I'm deep down in your gut, you already know this, that they are so entrenched in conspiracy theory that we do not have a solution for them. We do not know how to pull them out. One of the last slides, pulling somebody out that's deeply entrenched into a conspiracy theory is going to be like trying to rehabilitate somebody from a cult, right? That's the level of rehabilitation you have to think about. So there's not going to be a simple fix, right? But there may be strategies along the way we can develop. So big note of that. Sound good? All right, so our goals for this presentation. We're going to look at societal and interpersonal factors that influence mistrust. We're going to start talking about not only at the level of where institutions and governments fail to foster trust, but then also where does the individual break that down as well. We're going to look at some historical events that fostered mistrust in healthcare as well, and kind of use those as case models. Unfortunately, or maybe fortunately, we don't have a very many large-scale models that we can follow, but we do have some smaller crises that we look in this field. And then finally, the last part of the presentation, we're going to look at these three levels. What can governments do to help foster trust in healthcare? What can institutions do to help foster trust in healthcare? And what can we do, right? And we're going to talk about some of those strategies. All right. A lot of this presentation couldn't be possible without the work of David Shore at Harvard School of Public Health. He has a fantastic book, The Trust Crisis, Mistrust in Healthcare. His whole lab really kind of looks at mistrust in healthcare. Beyond this, there's a massive field of healthcare communication that looks at mistrust and how we foster mistrust or foster trust in healthcare. One thing that you're not going to also hear from me is I'm not going to regurgitate some Lencioni book to you. I hate Lencioni, and I can talk ad nauseum about that at another time. But I don't feel that this is where popular press is not where we're going to find solutions to this. There's actual scientific evidence on how we can approach mistrust. These two graphs on the side are just pretty obvious. The top one is looking at, it basically says, if your patients do not trust you, they are going to leave you. And the bottom one basically says that if your patients do not trust you, they're less likely to be compliant with their treatment plan. Pretty obvious, right? And so when we can look at how mistrust hurts patients, patients are less likely to ask questions about their health. This is going to be a really important point that we're going to explore in later slides too. When we look at our interactions with our patients, realize that everything they're talking to you about, they're going to go home and Google, right? And there are going to be questions that they're going to save for you, and there's going to be questions that they're going to have for ChatGPT. And that's just how it is, right? Mistrust, less likely to seek medical care when appropriate. I have my wife has an uncle who, I don't think he's seen a doctor in 50 years. And yeah, he can't feel his feet. I'm trying to get that guy in for some care, but he just does not see any benefit in doing that. Mistrust can also lead to dissemination of misinformation. People seek community, right? I hate to say it like this, but a lot of us are supportive of standards of care and vaccination recommendations because we're all part of a community that we support each other, right? And just like we support each other, the anti-vax movement, they have a real strong community. And so that dissemination of information is not necessarily a driving factor of mistrust, more so as a yearn for community, not wanting to be alone in your beliefs. This can lead to increased health costs, especially when we're seeing delayed care, and also irrational medical decisions. When we look at some historical perspectives of trust, in '66, we had some of the all-time high of trust and confidence in healthcare in America at 74%. Does anybody know what happened in '65? Nixon passed Medicare, right? And so we had a really big investment in healthcare around this time. Also, we see polio eradication, right, going into the late 50s. And so we had a couple of big wins there. There's also something interesting to side note with polio eradication. So we have the Salk and Sabin immunizations. So the Salk method was the inactivated polio virus. That immunization is actually probably one of the safest. Doesn't have a lot of side effects to it. Really, really effective. But then during its distribution, one of the companies that was compounding that immunization had some contaminants spill into a lot of the batches, which led to a lot of injury. And there was a public outcry about this inactivated polio vaccination. And so the public demanded a change over to the oral polio vaccination. So in later batches, you're seeing the little sugar cubes being distributed. And the oral polio, more side effect prone, not as effective. But the way America handled that it's kind of interesting because they acknowledged the concerns from the people, even though they knew exactly what happened with the inactivated strain. They started opening that option for the oral polio vaccination, and Americans really responded favorably to that, which was really nice. A lot of these statistics are still pretty solid today. We ranked 24th in trust in healthcare systems, and so that's out of 29 industrialized nations. But what I want to point out here is that our trust in our primary care team remains very, very high, third within industrialized nations. And one of the reasons that this is argued, especially with David Shore's group, is that healthcare is often used as a political tool. And then you get a lot of sensationalized media stories. And the 1-2 punch of this can make our patients mistrustful of the part of healthcare they're not seeing on a daily basis. And so that's probably what's weighing into a lot of this. But a lot of these numbers haven't really changed all that much, surprisingly, going through the COVID pandemic. All right. One of the things that we're going to talk about with institutions, it's important to have consistency in your messaging. And so, providing best care to our patients. But if you're an institution that's having a lot of, if we were just looking at the institution of healthcare, since I started medical school, so we had bovine encephalitis in horse meat. So, back in the early 2000s, we had, millions of cattle were destroyed for a disease that may present in some cases 3 to 8 years after exposure. So a lot of people were having a really hard time seeing that this prion disease was actually causing any problems, and especially in the cattle industry, they didn't like to have this lost revenue. Vioxx, this is an NSAID that was, at the time touted as this miraculous drug for arthritis, but turned out to increase things like stroke and heart attack risk quite significantly. Even today, we hear people concerned about flu vaccine and Guillain-Barré, even though that's become relatively uncommon. Back in the late 70s, we had a rushed flu vaccine that caused 9 out of 11 servicemen in Biloxi, Mississippi, to develop Guillain-Barré, and that's still very fresh in a lot of people's mind. And then I remember probably one of the very first patient mortalities that I witnessed in medical school was a gentleman who had a contaminated batch of methylprednisone injected into his spine with zerohylin. And he ended up passing away from an intracranial hemorrhage. So when we look at the institution, people see these sensationalized media coverages of things like this, and we lack consistency in our patient safety messaging. And that can be very, very harmful to trust, especially when it seems like every year or twice a year there's one big media story that's critical of healthcare. And then another thing, and I'm just going to show this video. They'll show up. Let's see.
Yes, ma'am.
I just want you to watch this video, and then
Please, Eric, please.
I want you to kind of create a differential in your mind of what's happening to this child. And if you have a hard time seeing, policeman lay the child on the ground, and yeah, they're doing chest compressions. Yeah, good rhythm. Stay into that. Stay into that. I'm joking because I know the child's fine, so I don't. All right, so some of the smartest healthcare workers that I've ever known are in this room right now. And what does your differential say probably happened to that child?
He was totally down. So, any number of things. Could have seized, could have had meningitis, could have had non-accidental trauma.
Yeah, maybe choking, anaphylaxis. Yeah, right. They were doing CPR, right? This is a nightly news report. This police officer won multiple accommodations for saving the life of this child who experienced a febrile seizure, right? So now, when you go into an emergency room and you have a family coming in, and with their child who just had a febrile seizure, and I sit them down and I they have to talk to a schmuck like me, and I'm turning to them and I say, yeah, this doesn't cause any brain damage. This probably won't happen again. It doesn't cause epilepsy. It's just one of those weird things kids do, right? If they saw this, they're going to think I'm crazy, right? If they didn't see this, they still think I'm crazy sometimes, just from some dirt in it. It was just a seizure, right? No. And so there's a disconnect between what the media is reporting and what's actually happening in healthcare. And so one of the things that one of the big things we can do to help foster trust is I encourage every one of you to, hey, reach out to your local media outlets. Talk to them. Provide them a consult if they have questions on maybe some of the new literature coming out in healthcare. The other thing we have to look at is where people are getting their truth, per se. So these are all factor loads. And so this looks at, so about, if you were to compare relatively, people are getting almost twice as much medical information from Google than they are from their doctor, right? They even have compared to WebMD, Google outbeats WebMD. Family and friends and doctors are all relatively similar in their factor loads as far as where people are getting their information from. This is kind of an older table. With the advent of ChatGPT, people Googling their diagnosis with ChatGPT is just exploding right now. And so this is something we're up against. We are not the primary source of health information anymore, right? We also have to stop attacking each other on social media. I can't tell you how frustrated I get when I find my way onto Facebook and I see certain specialties attacking other specialties, and not just like playful little poking at the bear, but really trying to trash another specialty to try to promote their own brand of care. So a great example, so many midwife groups out there that are just slamming OB and pediatrics, and trying to kind of add clout to what they do. I'll be the first to say, look, I think midwives have a really important role in healthcare. There's a magic to delivering a child and having that child in your home. And a lot of kids you can do that very, very safely for, right? And I think midwives provide that very, very important source of healthcare and magic for those families. But at the same time, when they're picking on OB and neonatal resuscitation, it fosters mistrust in that. And so people then, what they do is they say, look, I don't want to go to a hospital at all costs. And they start pushing the boundaries on what's safe at home delivery. And so they start saying, well, gosh, my blood pressure isn't too high. Oh, they're only 36 weeks. That's not too bad, right? And they start pushing those boundaries, and that's where kids can start getting into trouble. And so I don't find any benefit in I don't find any benefit attacking patients or patient encounters on social media, or joking about a patient encounter, because then patients, everybody's a patient. They're going to see that on social media and say, well, hey, if this guy's laughing about that patient's encounter, what are they saying about mine, right? And so that disrupts trust. The other thing that we have to worry about then is when we're attacking each other groups, again, it develops that mistrust, which then causes boundaries to be pushed as far as what we can do in healthcare. All right, so how do we fail to foster trust? There's a really cool series of studies that looked at SARS and H1N1 out of Taiwan, because they were pretty close together, but the public had a very, very different response to both. What happened with SARS in 2003 is that the government and the media didn't really pay much attention to it initially. And it wasn't until that the public outcry started fostering more attention towards SARS, that's when the government and media agencies started grabbing a hold of it. And they had a very, very strong response to SARS. They were basically like, stay indoors, don't go outside unless you absolutely have to. If you're coming down with a fever, a cough, respiratory illness, call your doctor. We're gonna have stations set up where you can be checked out safely. They mobilized a grocery delivery service. I mean, they just, all the bells and whistles, right? And they did a really good job at preventing SARS from escalating outside of the country. It would have a very low prevalence as a result. And I think, and correct me if I'm wrong, but I don't believe they had any more than 15,000 cases in 2003. But there was a high associated mortality with it. They had like 79 lives that were claimed. So then, and then they moved forward from there. After this, the WHO looked at this SARS response, and they made this statement, the 5 principles of communication combating a communicable disease: building trust, which is not simple, announcing early, which again, Taiwan didn't do initially, but they picked up pretty quickly. Being transparent, Taiwan was very transparent with SARS. They had no problem saying, you know, what they did and did not know and how they were addressing those conflicts. Respecting public concerns, they definitely listened to the public. And then advanced planning. Taiwan already had a lot of infrastructure in place for disease outbreak, and that allowed them to mobilize a lot of those respiratory illness stations and grocery delivery, etc. So then fast forward to 2009, and we had H1N1 that hit Taiwan, the swine flu. Oh no, this wasn't the swine flu. But anyways, in 2009, so H1N1 hits Taiwan. Something interesting happens. The government initially tries to do the exact same thing they did with SARS. Mandatory indoors, masking, respiratory stations. But the people fought back. They did not accept it. And one of the things that started coming up that they were wondering is that, well, gosh, because SARS in 2003 didn't have a lot of people infected, right, and only 79 deaths. Now, granted, that was probably those numbers because they had such an aggressive response. But the people of Taiwan were thinking, well, gosh, you know, we overreacted with SARS. I mean, not many people got sick and not many people died. This is just reactionary. This is sensationalized. And so they were not trusting of the government and the media when they were trying to say, hey, we need to lock this down. As a result, H1N1 would leave Taiwan and become a global flu pandemic, probably one of the largest ones in 40 years at that time. But, you know, one of the largest ones in 40 years at that time. But there's still a lot of communication experts that are looking at like, hey, what could be done differently? And so this is where we get into risk versus crisis communication. In risk, so there's 2 types of way that we can talk to a populace or a healthcare community about a crisis. In risk communication, this is more communication of uncertainty, heavily influenced by cultural and social factors. So this might be very nation dependent on what they experience. So in the case of Taiwan, they recently came out of SARS. Patients more likely to take a central role in planning. I think a great way of looking at risk communication is kind of thinking about this as almost America's first response to COVID, right? The first response was, yeah, there's this bug coming in from Asia. It seems to make some people really sick and not others. We're not quite certain who's at risk yet of really getting sick from this. At present time, we don't think it's going to cause much of a problem. But, just to be safe, try to just take personal precautions, right? A lot of the information that we're getting came from the media. We weren't really getting a lot of authoritative figures talking on COVID initially. And then you have all-out crisis mode, doomsday scenario, crisis communication. This is very, very precise, deals with visible hazards. Patients are usually very, very complacent initially. And so when you say, hey, we have a big old baddie that is killing people, and you do not want to get sick with this, and if you do get sick with this, we need you to call your doctor because we're going to need to check you out. We want you to stay indoors. We want you to take every infectious precaution. You know what? We're just going to go ahead and shut down the schools. That's kind of like what we're seeing more going after March and summer of COVID. This is also kind of the response that we saw from the SARS outbreak in 2003, which was much more definitive. The problem with crisis communication is that people become very complacent, which brings up a question of autonomy. You can only push that complacency for a certain amount of time before people start pushing back. And we'll have a slide on that in just a moment. A couple of curveballs to this, where big mistake we made with COVID is that this risk versus crisis communication is not your choice. It's the public's choice, right? So the public defines the risk, not the authoritative voice. And so in SARS, the public rallied up crisis communication on their own. And H1N1, the public had crisis communication attempted to be imposed on them. One, they didn't think it was crisis. They were like, gosh, these are just sensationalized stories. And so you didn't get complacency in 2009. You got resistance. And also for pediatrics, parents are less likely to perceive risk pronouncements of the medical community as valid if those pronouncements involve the health of a child. So parents are naturally more skeptical. All right. So we look at COVID, first case identified in 2019. Within a year, it had 60 million infected, 1.32 million dead in the United States from COVID. Last time I checked, that might actually be higher because I actually think there's 1.6 million statistic, but still a lot of people in a very short period of time. And I want you to see what happened here. So we start seeing our first cases in Western Washington going into February, late January, February. And then interestingly enough, we're kind of baseline in looking at misinformation online. This is a Google Trend study looking at how people are Googling misinformation. And we always get this underlying misinformation, right? But then something happened here and we saw a spike. So we have COVID in the United States here, but then we see the spike. What happened here? Yeah, we closed our schools, we locked down, right? We put a lot of stress on our populace when we did that, and then people started Googling like crazy. The other thing here is that, people would argue that in crisis communication, you have a temporary complacency, but a lot of people are also arguing during this time we weren't using crisis communication techniques. We were using risk communication techniques. And so I don't think the type of communication really was contributable to that spike. I think that spike is more towards the stress that we put on the populace. All right. And we've all seen these memes. I mean, there's so many to count, but I mean, it just got to be inundated with just misinformation online. I mean, I know a lot of you probably look at these and your gut just turns just looking at them. Like, we can't identify with this, but a large segment of our population did. And we're going to talk about why that is. All right. So lack of transparency, that's risk communication. In late February, we were exporting a lot of our medical supplies. We didn't really have a unified message. Going into late February, we had the CDC and the NIH that were saying, hey, we really need to buckle up. But then we had other leaders that were like, this will probably be gone by the end of the summer. And so we didn't have a unified message. That was problematic. Lack of clear understanding of leadership through this pandemic. This all led to more of a risk communication strategy that was adopted more by the people as a result of seeing a lot of this. And as a result, you created no complacency, or little complacency, or I should say insulted complacency, I should say, that'd be a good word to use, or insulted motivation for the public to actually follow recommendations, right? Again, complacency is kind of an ethical question because we worry about autonomy, and I get that. But when you have a lack of a uniform message, this is one of the things that are going to breed behaviors that are like, hey, you know, I don't understand why I have to wear a mask, right? Rather than just wearing the mask. And so communication is long thought to be one of the breeding points for some of the misinformation that started taking hold. Something I want you to keep in mind when it comes to conspiracy theories and misinformation is that we're all vulnerable to it. This isn't a one group of people that is more susceptible to others. Now, with each instance of crisis, you may find certain segments of the population that are a little bit more vulnerable to that crisis, but all of us have the ability to subscribe to a conspiracy theory, if the right conditions are met, right? And so this looks at a lot of different conspiracy theories based on where your political leanings are, and it's pretty interesting to look at. My mother-in-law, she's Bigfoot and UFO conspiracy. I went to a MUFON meeting with her once. That was awesome. But then after COVID, I just can't tolerate conspiracy theories anymore. They twist my stomach up in knots. So mistrust is universal. No matter what your education status, what your age is, what your background is, we're all susceptible. And chances are, each one of us in this room have a tightly held conspiracy theory that it just makes sense to you. When it looks like you look at alien cover-ups. I used to find it fun thinking about aliens and UFOs because it didn't hurt anybody, right? It's just neat to think about things like that, and that's where I took it. But when the conspiracy theory starts being pervasive and disruptive to a community or to the health, then I think lines get crossed. Yeah. So this is the pathway for mistrust, and I'm really simplifying this down, but I think it's a really good model to look at. Most mistrust starts with a stressful event. When you have somebody that is tightly held onto a conspiracy theory, like my mother-in-law. My mother-in-law believes that that there's this massive government cover-up of UFOs, and that that Bigfoot is real and can turn invisible and talks to people, and she is just just wrapped up in that, right? She wasn't like that 10 years ago, right? What happened in 2016? Well, her husband passed away, right? And then soon after her husband passed away, she started getting into a lot of these conspiracy theories. and they weren't harmful, right? But they exercised her mind, they got her involved with communities. In a way, they were very, very helpful in that regard. Look at what happened with COVID, though, right? COVID, we go on lockdown. People lose job security. People are terrified about the health of family and loved ones. People are worried about losing their homes. People don't know what the future holds. This is an incredibly stressful event. And there's a ton of literature that looks at stressful events breed mistrust, right? What ends up happening initially is after the stressful event, there's usually social conformity. You have no idea what is happening, and so what do you start doing? You start looking around and seeing what other people are doing. And then you just kind of follow that lead, kind of like almost like a pack mentality. And then you start questioning what you're doing. Is this really helping? Are these masks really helping? I just hate wearing this thing. And then you start kind of exploring deviating from the pack with biased reasoning. So you're like, well, gosh, these masks, I don't know if this is actually helping or not. I can't breathe in this thing. I'm just going to pull my mask down just for a couple minutes while, chatting with friends, just to get my air, right? And then, well, that didn't cause any problem, so it reinforces it. But it's kind of like a pathway towards misinformation. But eventually, the misinformation becomes part of the identity. And you get wrapped up into it, and you become so invested in it that you just take it as your truth, that, hey, these masks aren't doing anything. And so anybody who tries to make me wear a mask, I'm going to fight back on, because there's no reason for that, right? As providers, you are not going to change these people. If you do, that is a huge career win, right? When it becomes part of your identity, you experience cognitive dissonance. And what that means, and this is a whole field of study that started in the 50s, but interestingly enough, when you're so wrapped up in a belief that no matter how much fact is thrown against it, you just wrap into it even tighter, right? And so we'll talk a little bit more about cognitive dissonance in a little bit. As providers, this is what we're targeting, all right? The golden circles here, right? So when we're looking at, gosh, we have a patient that, gosh, they just had a death of a loved one, or they just moved, or they just lost a job, right? We're doing our social history, right? This is a really good time to be really particularly paying attention to those PHQ-9s and GAD-7s and making sure that these patients feel supported, right? They may be going through a stressful event, and this social conformity here, still a good time to talk about why we're doing these recommendations, right? So this stressful event may have nothing to do with anti-vaccination, but after that stressful event, they might start thinking, well, gosh, yeah, we're doing immunizations, but, I'm starting to think, are these actually helpful, right? Yeah, gosh, my partner passed away from cancer, and I thought the chemo was going to work, but it didn't. And well, now I'm starting to question every intervention in a hospital setting. And so you may have somebody that's completely agreeing to all the immunizations. It doesn't mean we should be avoiding that conversation with them about why we're doing them, and still talking about those facts, because they may be starting to question, and you want to make sure you've had a chance to talk about why we do these things, right? Even when they're questioning here, introducing facts, having heart-to-heart conversations with our patients can help deter away from this mistrust pathway. When we're down here in biased reasoning, out in Washington State, I'll be honest, and I know there are providers out there that think what I did was probably criminal, but there was such a mistrust of immunizations out in Western Washington that I would negotiate. we did not see hepatitis B out there. We just didn't see it. And I didn't see Hep B. I didn't see any Rota while I was out there. And so those became negotiating tools. Be like, look, I understand, Mom, how you're concerned about all these immunizations being given to your child. And to be honest, you deferring Hep B in the nursery, I'm not losing sleep over that. But I really need you to consider DTaP, and this is why, right? That negotiation tactic allowed me to get at least some coverage on board, right? I saw a ton of pertussis, and I really wanted my families at least to protect themselves from pertussis. So as long as I didn't come in an all or none kind of mentality, hey, these are the recommendations, take it or leave it, they're gonna leave it. But if I went in there and I said, look, I'm okay if you avoided Hep B, we can deal with that, but DTaP, I really need you to consider that, and this is why. This is where we're trying to target our populations, not here, right? This is just trying to get somebody out of a cult, okay? So what can governments do to improve trust? Anything that reduces a scarcity mindset. And so what happened in COVID is people lost their jobs, people were having a hard time paying rent, people are afraid for health. And what did we do? We needed an economic stimulus to keep the economy going. Spending was dropping, and spending is the engine of the economy. And so we needed programs that would get the economy going, and that's where the leadership focus was. But they really lost an opportunity because one of the stimulus programs, I thought this was great. I mean, but they were targeting Americans who had student loans. And now granted, I think, yeah, there is a student loan crisis. I get that. But people who were carrying educations were not hit as hard as people who did not have a four-year degree. And I really think that the investment in those programs should have really targeted people who did not have that four-year degree, because that would have reduced their scarcity mindset and then reduced the risk of fostering mistrust later. Transparency is incredibly important. Don't try to hide anything from the public. They're too good detectives. And then do not force risk versus crisis communication. Even during the shutdown, leadership was talking in a risk communication mindset, which when you're in a shutdown, you're in crisis mode, right? So that was an incongruent communication strategy. Remember that the population determines your communication, not leadership. Institutions. This could be the whole medical institution. This could be a hospital. But how can we improve trust? This is something that we're doing chronically. This isn't something that we look at doing in one moment. And probably one of the most important things that an institution has is its employees. Carilion has 14,000 employees serving over 500,000 people, right? That's 1 out of 30 people in Southwest Virginia is affiliated with Carilion, right? If your employees are treated like rock stars, and they come home from work with a big smile on their face, I guarantee you that's going to pay off in dividends to your patient population. They see a Carilion employee who just can't say enough good things about the place that they're working for, and people are going to have trust in that institution, okay? Public transparency. Again, hospitals are going to be part of that risk versus crisis communication. And you really have to weigh, where is your public at? Are they in a risk communication or are they in a crisis communication? And tailor your words to that. Try to foster community resiliency. People that are involved with sports, with extracurriculars, with the arts, tend to have a lot more resiliency. And what do you see a lot of large hospitals doing, right? Gosh, we have game night with the hockey team in town, the Rail Yard Dogs. We have Salem baseball night, for Carilion. We do a lot of outreach here, which is fantastic because this outreach is helping foster community and resiliency. All institutions need to follow consistency in their messaging, credibility, scalability, and sustainability. So consistency in messaging, let's look at like, gosh, if you're a small rural hospital 30 miles outside of the Mayo Clinic, does it make sense for your mission statement to say, we are going to deliver the best care in the world? Right? That doesn't make sense, right? You have to know what your limitations are, right? As a community clinic, you have to know those limitations. And so credibility is also, influenced by that. And then are you able to maintain that messaging and consistently demonstrate that messaging? So if you're a hospital that is going through financial struggles, I got to move it along, I'm sorry. If you're a hospital going through financial struggles, you may see a lot of crises hitting year after year after year. Those crises are hitting your consistency. And if they're hitting your consistency, people are losing trust in your institution. All right. I talked about a lot of these things already, especially in those golden rings. Try to get involved with local media. That can help improve messaging in a community. Social media even. I know a lot of people have a lot of enjoyment just talking about developments in healthcare or at your organization. Body language is incredibly important when talking to families. Eye contact. Try to keep your eyes below the level of your parents. Just a couple of, I think a lot of us know a lot of these body language tools that can really help engage trust. There's a disconnect between competence. We think our competence is based on our knowledge and skill set. Patients see competence in the use of words. And so if you start talking in definitives, if you start saying things like, I don't know, I think it might be, that loses confidence in your patients. But then again, we're scientists, and so we're never 100% confident, right? And so trying to navigate that. And the way we can navigate that is just talk about the scary stuff. Talk about the what ifs and how you're planning for it, right? I like to tell my families, hey, I got a plan for if I'm right, and I got a plan if I'm wrong, right? And we go forward from there. The more prepared you appear to be to your patient, the more trust they're going to have in you. Conspiracy theorists are always going to be 10 moves ahead. Anti-vaccination is not new. I mean, that's been around since the first vaccinations. During the Revolutionary War and also Civil War was a big one, where we had a lot of people getting sent off to war, and what they're doing is they're going into camps, and sometimes they're getting inoculated from smallpox, and a lot of times they were just dying in disease just in training before they even saw the battlefield. A lot of families were like, what's the point? And they're questioning a lot of that. But anti-vaccination has been a big deal. Mandatory vaccination, we've done that historically. In the UK, in the early 1900s, they tried to pass mandatory vaccination, and the public almost burned London to the ground as a result. So mandatory vaccination seems like something that looks good on paper as far as protecting the health of our populace, but socially, be prepared for a lot of resistance. Try Googling, should I vaccinate my child sometime? That's a lot of fun, and go to some of those anti-vax groups. Those websites are colorful. There's tons of community. There is all these really cool gadgets that they advertise, like Nose Frida, and they're like, oh, I didn't know those things existed. And the websites are a lot of fun, right? And that's problematic, because if you read the CDC's website on why we should give our kids DTaP, it'll put you to sleep. Yeah. And so their messaging is a lot better than ours, right? But the big thing is that conspiracy theories and people that are really identify with misinformation, their community is huge for them, and it's very, very difficult to break that. What I want to leave, last message here, this is me getting the first jab. My 5G reception was awesome. But let's look at the COVID immunization. The COVID immunization was developed, or mRNA immunization technology was developed out of mistrust, right? So after the Wakefield study, people were really starting to question these immunizations, kind of renewed interest in questioning immunizations. There was a big focus on adjuvants and why we're giving all these adjuvants with these immunizations. mRNA doesn't really need adjuvant. You just coat it in oil and deep freeze it, right? So we removed the adjuvants. A lot of people were worried back then about all the multiple pokes that these kids were getting. Theoretically, you can string all these immunizations together in one immunization, one mRNA poke. And so this is a technology that was developed because the people were concerned about risks associated with immunizations, and they were trying to reduce those concerns. And so we see a lot of improvements after mistrust. Our modern medical system was developed because people did not trust what the American healthcare was doing. And a lot of our standards and regulations came out of mistrust. So we can get a lot of benefit from mistrust, but just kind of keep that in mind. Anyways, I kind of rushed to the end there. I'm so sorry at 8:30. Any questions?
Given some comments online, Dr. Kraft mentioned earlier when you were talking about the
Which
Medicaid
Dr.
care.
Kraft?
Hugh Kraft.
Oh, okay, all right. Hi, Hugh.
He commented the AMA and organized medicine fought the passage of Medicare quite aggressively. He also said vaccine discussions and vaccine hesitancy or deferring patients offers perfect situation to explore shared decision making. Dr. Gulick mentioned earlier when you were talking about scandals in medicine, the opioid crisis.
Oh, yeah. It's a huge one.
And Dr. Hart said excellent presentation.
Oh, good. Thanks for the comments, all. I have some questions at the end of the presentation I think you could probably look through on your own. But what I was trying to aim for is, like, right now we're at the precipice of gene editing therapies. And so it's good to kind of think about mistrust and what we can do to help usher in gene editing therapy, which is just absolutely wonderful. Or I think it's absolutely wonderful. I think there's a lot of really great opportunities there. And that's probably something that's going to be targeted in no time by misinformation, if not already. And then, gosh, down the road, we're concerned about a large measles outbreak. We're concerned about, we have these diseases like cyclosporidia that are hitting, and just thinking about how can we cushion the blow of these crises in a way that helps us foster more trust in healthcare. Try to get ahead of it rather than trying to chase the 8-ball.
And I would just encourage, I'm sure you have these conversations, but for the residents, right? Have these conversations with your attendings. To me, when this first started, I got very, very angry. And now I see it as the art of medicine. And like, this is the way to be creative. This is the way to act. Like, a textbook doesn't tell you how to do this. This is the way you can only figure out how to do it when you're in the room with the patient. And so this is where, to me, it gets fun. Because I just need to know you, I need you to know me, and then we need to have a conversation. And so this, I believe, is really the art of medicine, and this is why we got into medicine, not because we can regurgitate textbooks, but because we get to blend art and science. And so just see everybody as an opportunity to be curious, and an opportunity to meet them, and to do the most good with what you have.
I have a question. I wasn't in the US for the COVID crisis,
Sure.
so I lived it in a different, but I feel like one of the things that we had is communication fatigue from the authorities, and the way that everything was like being told again and again. Like, we had police enforcing the stay home kind of thing. So it was more hardcore, but I feel like it was. But I feel like that happens with our families sometimes. Like, you get people in the hospital who are there because they're concerned about their baby, but at the same time, they are very resistant to any sort of medical intervention, including like IV fluids. And so how do you talk to them when they think they have already heard everything they want to hear?
Yeah.
and they are not going to talk to you, but at the same time, they're here for care for their baby. And so
Right.
that can become very frustrating.
So you're talking about those groups that are in that area of misinformation where it's become part of their identity. They've reached that conspiracy theorist kind of mentality. If I can't get them to listen to standard of care, right, then maybe I can start listening to that very first stressful situation that triggered all of that, right? So, maybe I just start reading, and I'm not going to change anything in that appointment, right? But maybe we should start talking about, hey, gosh, that move 3 years ago was really, really hard on you, right? And let's talk about that a little bit more. Make sure that we're addressing underlying things like anxiety and depression. And by talking about those stressful events too, you're developing empathy with that patient. The patient is feeling that empathy and feeling like you're there to support them, right? So we're not going to get them to trust an immunization in that appointment, but maybe over a couple of appointments where we're just checking in and just say, hey, how's that divorce going for you, right? Eventually they get to the point where they start feeling, hey, this is somebody that really does care about me. And maybe they start saying, well, gosh, maybe I am ready for that MMR. Let's just try that.
In the hospital.
Oh, in the hospital, though, yeah. We get those patients a lot. And again, I can't do changes overnight. But I think, especially with our child life, and I've seen our social work do this too, where if you look at their communication strategy, it seems like they are focused on, like, this is causing you stress, but let's talk about what's underlying here first. Let's just see how you're doing personally. Let's talk about you before we talk about the treatment, and I think that goes a long way.
Thank you.
Show that you care more about the person rather than the treatment.
Thank you.
Yeah, thank you.